But as was just said, when you dig into someone's CV a little bit, you really see what they're interested in and what their real expertise is. And so I think, you know, Dr. Nett in particular has an interest in reflux and endoscopic treatment of achalasia, and is going to speak to us today actually either about some of that or just a general potpourri of what he does. He comes to us here from CPMC, where we've been colleagues for 5 years now. He comes to CPMC by way of Michigan, where he did his advanced training, and then the rest of his training was at UCSF. So he's local. We're lucky to have him here, and Andrew, I look forward to your talk.
All right. Thank you, Will, and thank you for the invitation and the honor of presenting today. Will, also thanks for giving me a fairly broad topic so I could really talk about whatever I wanted. But to start, you know, I think in general, interventional endoscopy is kind of behind general GI in terms of the standards and rigors of the research that's being conducted. A lot of it is basically just procedural outcomes at a very basic level. Although I think that there are a few different areas over the last year and a half where there's been some consolidating evidence published that I wanted to share today. And then later in the talk, you know, I think POEM has been around for a while now, but there are various applications of POEM that are exciting, and there's some recent preliminary evidence to share related to these procedures. So to start with EOS-guided gastroenterostomy, the technique now, which involves use of a lumen-opposing metal stent, was first reported in animal models by our sort of group leader, Dr. Binmoller, and former colleague, Dr. Shah, in 2012. But since that time, there's been I think, simplification and standardization of the technique. In particular, at our center, I think, you know, we have a fairly simple procedure. This involved use of an oroenteric catheter, which is used to fill the small intestine lumen with contrast and water to provide a better target for direct puncture using the electrocautery enhanced device. So in the video here, you see basically the technique that's used, and we recently published a retrospective case series describing this in endoscopy. But essentially, a guide wire is passed under fluoro through the stricture lumen into the normal downstream small bowel. What we're using here is essentially a feeding tube catheter is passed over the wire, and then water is infused through that. Here you can see the EOS direct puncture into the lumen of the small bowel with deployment of the distal flange. So in this series, you know, this study involved 40 patients. The technical success report it was 98%. Mean procedure time is 36 minutes with no serious adverse events. And overall, 93% clinical success at about 6 months was observed. That was defined as a non-liquid diet. So just to finish the video, here you see the lumen-opposing metal stent is deployed, dilated, and then visualization of the afferent and efferent jejunal limb is performed. And then this is just an upper GI series showing passage of contrast into the downstream small intestine. Okay, so also this year, a retrospective comparison of EOS-guided gastroenterostomy versus surgical gastrojejunectomy was performed, and this is looking at data from our center, but actually the lead author on this is Abdul Kawanda, who's the graduating advanced endoscopy fellow over at UC, so thanks to Mustafa for letting him spare some time to help analyze our data. This involves 66 patients with either benign or malignant causes of gastric outlet obstruction. And what was seen is essentially comparable rates of technical and clinical success. The time to PO intake is significantly shorter at 1 day following EOS-guided bypass. The length of stay was also significantly shorter. Chemotherapy was resumed earlier, and the procedure time was dramatically shorter. Of note, A solid diet being tolerated was reported as being less following EUS-guided GJ, although this is specifically at the time of discharge, so the patients were discharged fairly quickly, so I think this in part reflects that they just didn't have time to advance the diet fully. This study also showed lower adverse events with EUS-guided drainage versus surgical bypass, with reduced rates of infection, ileus, and acute kidney injury, and there was no difference found in symptom recurrence, reintervention, or readmission or death within 30 days. I think not surprisingly, the EUS-guided gastroenterostomy is significantly cheaper. So another study published this year looks at retrospectively basically multiple studies that have been published using a comparison of EUS-guided gastroenterostomy versus surgical bypass, but also comparing EUS-guided GJ versus enteral stents. Starting with the comparison to surgical GJ, and this is specifically a malignant gastric outlet obstruction, this study review basically showed equivalent clinical success between the two techniques, although there was lower technical success with EUS-guided bypass. But EUS-guided bypass resulted in shorter length of stay, and the two techniques had comparable rates of reintervention and complications. Looking at EUS-guided gastroenterostomy versus duodenal stent, this study found basically comparable technical success, but otherwise improved outcomes with EUS-guided gastroenterostomy. So transmural bypass resulted in higher rates of clinical success, fewer adverse events, including decreased stent obstruction and tumor ingrowth, and decreased need for reintervention. So I think this is not a randomized controlled trial, but fairly compelling evidence for an approach where the first-line therapy is transmural bypass rather than enteral stenting. And I think at many centers, that's sort of the approach that's now being taken. Another area of use for the lumen-opposing metal stent is for gallbladder drainage. So I think an interesting study published last year by Anthony Teo was an examination, actually in a randomized controlled trial, of the best treatment basically for patients with acute cholecystitis that were not surgical candidates. So this was a multi-center trial that compared percutaneous drainage versus EUS-guided drainage in very high-risk surgical patients, and that was defined as having an age greater than 80, having an ASA of 3 or higher, high comorbidity scores or low performance status, and then this high-risk group also included elderly patients that refused surgical intervention. So in this study, the protocol for EUS drainage is basically use of a 10 millimeter or 15 millimeter lumen-opposing metal stent that was dictated by the size of the largest stone visualized within the gallbladder. At the discretion of the endoscopist, another pigtail plastic stent may be put through the lumen-opposing metal stent lumen. In patients that got EUS-guided drainage, they had endoscopy with cholecystoscopy at 1 month follow-up to assess for stone clearance. And basically, if the gallbladder was empty of stones, then the lams was removed and a permanent pigtail plastic stent was placed across the cholecystoenterostomy tract. If there were still stones, then monthly endoscopy was performed until stone clearance was achieved. If patients were too old or frail to have any follow-up procedure, then the initial stent was just left in place permanently. For the group that got percutaneous intervention, basically a tube check or cholecystogram was performed at 1 month, and if the cystic duct was patent, the tube was capped or removed, or if it was obstructed, the percutaneous drain was pursued indefinitely. So here you can just see EUS-guided cholecystoenterostomy. This is the gallbladder with a very thick wall and a lot of septations consistent with cholecystitis. This is a direct puncture method. We're using the electrocautery enhanced LAMS device. So we have deployment of the distal stent flange within the gallbladder lumen, and then deployment in the proximal flange within the GI lumen. And I think this is cholecystogastrostomy, which sometimes we prefer if there is a chance that surgical intervention may be pursued in the future. Otherwise, I think the preferred site of transmural puncture is in the duodenum. Okay, so going back to the trial, 660 patients were screened. Most of these were surgical candidates, and 40 were excluded because for various reasons, but including the presence of gangrenous cholecystitis or perforated cholecystitis, or the presence of prior drainage. In the end, 40 patients were randomized to EUS-guided drainage, and 40 were randomized to percutaneous drainage. And this trial showed no difference in technical or clinical success, but significantly less recurrent acute cholecystitis at 30 days and 1 year in the EUS-guided gallbladder drainage group, with associated lower rates of readmission and reintervention. In addition, the EUS-guided drainage group had significantly less 30-day and 1-year adverse events. So I think that's fairly compelling evidence to actually shift first-line therapy for non-surgical candidates to EUS-guided drainage rather than percutaneous drainage, where expertise is available. Anthony Teo also looked at a comparison, basically using, I think, some of the same patients, of EUS-guided drainage versus actual surgical intervention with a lap cholecystectomy for acute cholecystitis. This was a propensity score matching study in order to compare these high-risk non-surgical candidates to surgical candidates getting cholecystectomy. Only 1 year follow-up is available for this, but it essentially so far shows non-inferiority, although certainly I think with the risk of stent occlusion, the longer-term outcomes may show some kind of stratification in outcomes. Okay, so moving on, another topic for which we have some more data published in the last year is EUS-guided glue coil embolization, specifically for primary prophylaxis for gastric varices. So a relatively large series was reported in 2017. Most of those patients were patients that had actually bled. So the question is primary prophylaxis with glue coil embolization warranted? This is a single-center study of patients at CPMC, a total of 82 patients, most of whom had cirrhosis. The mean variceal size was over 2 centimeters, and almost 90% of these patients had IgV1 type varices, and the historically reported bleed rates for that are nearly 80%. The mean length of follow-up was 3 years. 1.5 coils on average were used with 2 cc's of glue. 100% technical success was present. And then in patients who had follow-up endoscopy, confirmation of obliteration of the gastric varices was achieved in nearly 100%. Most of the time, patients only needed 1 encounter or 1 session of glue coil embolization, and then a large majority had obliteration of their varices in 1 or 2 sessions. So overall, I think that this series showed high clinical success and relatively low adverse event rates. There was about a 5% adverse event rate, though, and this included 2 patients that were admitted essentially with abdominal pain post-procedure for 1 day. 2 patients did have pulmonary embolism within 2 weeks. One, this was attributed to the glue embolization, and another, it was attributed to a pre-existing DVT. All right, so another topic is basically anti-reflux endoscopic therapy. So for TIF itself, which has been around in some iterations since 2008, I think that the data is fairly static in terms of not much being presented over the last couple of years. But in practices that are performing anti-reflux therapy, I think one very frustrating thing is that most of the patients that are referred for TIF or for endoscopic intervention actually have anatomy that disqualifies them from TIF alone. In particular, their hernia size is too big or the diaphragmatic hiatus defect is too large. So if you perform TIF alone, you expect quick recurrence of a hernia and suboptimal outcomes. So what's being done in these patients is basically concomitant TIF or C-TIF, which combines laparoscopic hiatal hernia repair with endoscopic fundoplication. So here you see basically surgical repair of the diaphragmatic defect with crural closure around the distal esophagus after hernia reduction. And this is just the before and after of that step. Here you see the hiatal hernia with reduction of the hernia and closure of the hiatus, followed by the endoscopic fundoplication. And part of the rationale for this is essentially, we want to achieve the goal of durable hernia repair and reduction that's achieved with surgery, while avoiding the long-term structural side effects that are associated with traditional Nissen fundoplication. In particular, or as an example, gas bloat is reported at about 30% of patients following Nissen, and the rates reported in the literature following TIF are 0 to 1%. So there are a few series looking at this C-TIF procedure. The first was reported by Peter Janu in 2019. He operates out of Appleton, Wisconsin, which is my hometown. This is 100 patients. They looked at PPI usage before and after the TIF. At baseline, over 90% of patients were on at least a daily PPI. At 1 year, 75% were never taking a PPI. And importantly, no increased rates of gas bloat, inability to burp, or vomit were noted. The second series, let's see. Sorry, I think it's frozen. Okay. So the second series was reported in 2019 as well. The difference for this one is, they had almost a year follow-up. It showed significant symptomatic improvement, but also they looked objectively at acid measures, including with basically pH studies. So the pH score was overall improved significantly, and in patients at follow-up endoscopy who had an intact structure, an intact wrap, 95% had normalization of their esophageal acid exposure. And then finally, the third series looking at this concomitant procedure was published out of UCI. Let's see if it comes up here. Is there another way to advance? Do you know? Here we go. Okay, so this is, similar outcomes, basically. These were 60 patients who had large hiatal hernias, 100% technical success, significant improvement in their symptomatic scores, and nearly significant improvement in objective acid measures. In this series, about 80% of patients were taking at least daily PPI up front, and then at 1 year, 5% of patients were taking PPI. Beyond the TIF, there are a number of basically procedures that have been reported over the last several years that involve essentially something done to the gastric cardia or distal esophagus to induce stenosis and tighten the GE junction to try to limit acid reflux. One of these, one of these was basically like an observation out of Japan where patients who got mucosectomy for treatment of Barrett's was being performed, and I think one patient said, what did you do? My reflux got so much better. And so after that, Dr. Inui basically looked at a series of mucosectomy for treatment of reflux. But more recently, what's been looked at is essentially AntiReflex ablation. This series in 2020 was small. It involved 12 patients, but of note, this is in patients with Hill grade 3, so these are patients who would not be a candidate for TIF or endoscopic fundoplication. The technique used in this case series was submucosal injection followed by spray coagulation, and at least short term, there was an improved acid levels with decreased Demeester score and improved symptomatic survey scores. In a larger series, AntiReflex ablation was reported last year in patients with Hill grade 2 or 3 GE junction anatomy. These patients had refractory GERD despite BID PPI, abnormal objective acid levels, erosive esophagitis, and abnormal survey scores. The technique used here was hybrid APC, so submucosal injection followed by APC, burning of the gastric cardia. This involved 180 patients. Clinical success defined by normal esophageal acid exposure levels was seen at 3 years in 70% of patients. With all of these, either mucosectomy, resection, and plication, or ablation at the gastric cardia, we see about 10% rates of stenosis requiring sometimes multiple sessions of dilation. Or sorry, I should say symptomatic stenosis with dysphagia. Okay, so then the last sort of update before we get to the POEM innovations is basically the role of IV hydration in post-ERCP pancreatitis prophylaxis. Patrick Avila at UC conducted a survey of advanced endoscopy fellowship faculty, and 83% of patients, 83% of responders in 2020 reported that they're using IV fluids to prevent post-ERCP pancreatitis. But is there actually benefit for this? So this year there was a multi-center open-label RCT that was published, over 800 patients comparing basically rectal NSAID therapy versus rectal NSAID plus aggressive hydration. And what was shown is that in moderate to high-risk patients, basically there was no difference in post-ERCP pancreatitis between the two groups, with no difference in complications or basically ICU admissions or 30-day mortality. Okay, so now here's just some preliminary evidence. POEM has been around since it was 2008 when it was first performed in humans in Japan, and since then it's been applied to various different locations in the upper GI tract. I think the most recent sort of published application is the use of POEM for treatment of cricopharyngeal bar, which is just essentially hypertrophy or fibrosis of the cricopharyngeal muscle with resultant symptomatic dysphagia that results from either trauma or recurrent acid reflux-related injury. So at DDW this year, a multi-center study looking at 27 cases was reported showing 100% technical success with low adverse event rate, with good, basically, clinical success in all patients, which is defined as a decrease in dysphagia score over 2. And only one patient at 3.5-year follow-up had symptom recurrence. In the video here, you can see that ridge, which is basically the cricopharyngeal bar. And then the standard technique for POEM involves submucosal injection, mucosotomy for tunnel creation, submucosal dissection, and then myotomy. So here you can see they're tunneling in the submucosa. There's some fibrosis, as evidenced by the charring here. You can see the muscle fibers there. Okay, and then the ridge of muscle, which is the cricopharyngeus here. Okay, and then myotomy is being performed. They switched knives here. This mucosal flap, I think, kept coming down, so this is an insulated tip knife to help protect the overlying mucosa. This is examination of the esophageal lumen to make sure there's no inadvertent mucosotomy more distally or cautery injury, and then closure with short stem clips. In addition to cricopharyngeal POEM, a application that's relatively new for POEM is basically treatment of Zenker's diverticulum. And there are a few different studies with updated evidence for this. In DDW this year, basically there was a comparison of conventional endoscopic septotomy versus ZPoem that was reported. This involved 52 patients, and what that study essentially showed was significantly fewer adverse events for ZPoem technique. Traditional ZPoem technique involves starting your tunnel with mucosotomy above the esophageal lumen within the hypopharynx. A modified technique was reported last year by Dr. Rapisi, which looks at basically starting the tunnel directly over the septum of the diverticulum. This showed good clinical success and very short procedure time of less than 14 minutes. Almost all of these patients were discharged on the same day. So at DDW this year, there was a retrospective comparison looking at the standard ZPoem technique versus this technique where the mucosotomy started right over the septum. This didn't show any difference in procedural outcomes, except shorter procedure time was noted, again, with the modified technique. Okay, and then finally, underwater ZPoem was reported at DDW this year in a series involving 30 patients. about 30% or 30% of these patients actually had prior treatment, mostly with actually surgical myotomy performed by ENT. So the procedure time was 40 minutes, technical success 100%. The follow-up was about 41 weeks in 21 of these patients. An Eckert score of 0 was present at final follow-up. One patient had a contained leak managed conservatively, and one patient had a stricture that was treated with dilation. So here on the video, you can see the standard poem technique being performed, but underwater, which it helps to basically highlight vessels, and also the buoyancy basically of the submucosa helps to separate the tissue layers somewhat. This is the myotomy being performed. So here at the bottom, you see submucosa between the muscle and the diverticulum. And then at the top is your esophageal lumen side. So the myotomy is extended down to the esophageal wall. And then again, clip closure is performed. Okay, so then a big question, especially in younger patients with achalasia, has been, is it still worth doing surgical myotomy with the door fundoplication, since we know that higher rates of esophagitis and symptomatic GERD have been reported following POEM versus the Heller myotomy. So just to kind of summarize or give some data behind the incidence of GERD following POEM, this is a series Stavros Stavropoulos reported this year at DDW. This is basically an 11-year history of the POEMs that were performed at his center. Half of patients never had GERD, but 15% of patients had at least symptoms 2 times per week. So various techniques are now being proposed for treatment of GERD. I think, generally the rate of esophagitis is about 45 to 50%. The rate of symptomatic GERD, we just quoted, but many of these patients have symptoms controlled with PPI, so I don't think we're necessarily at the point where we need to do kind of preemptive intervention. But this is a series in patients who had symptomatic daily GERD 75% of the time, and over 90% of these patients were on BID PPI after having POEM. That essentially was treated with TIF in a second session. So the outcomes showed 100% technical success and significant decreases in PPI use, GERD symptom scores, mean Demeester, and esophageal acid exposure. In follow-up to this same session, POEM and TIF has been pursued and reported recently. So this is a series that's small, that started basically with demonstration of technique in animal models. And then next was performed in 5 patients. So in this, you basically have completion of the myotomy. Now they're actually marking where the underlying myotomy is performed, just for orientation. And then the TIF is performed. So here they're grasping, I think, and plicating the posterior side. And then the same thing anteriorly. Here you can see the small marking, which is the orientation or site of the tunnel. And that's done to avoid putting basically these fasteners through an area where the only layer left behind is just the mucosa, to try to prevent a leak. So they're looking then at the tunnel again. You can see there's some distortion at the end of the tunnel from the fundoplication. So in this small series, no intraprocedural delayed complications were reported. There was normalization of Demeester in 80% of patients. One patient continued to have symptomatic GERD with esophagitis. In retrospect, it was noted that this patient had a hiatal hernia despite having achalasia, and perhaps it wasn't a great candidate for TIF in general. There's some speculation that part of the added benefit of performing TIF with POEM is that you also have basically so the intra-abdominal esophagus is lengthened and the esophagus is pulled down somewhat, so that may provide some straightening. So if you have patients with a fairly tortuous esophagus or dilated esophagus, lengthening and shortening the esophagus might reduce residual symptoms following myotomy. And then just the last couple things I wanted to show. So here is actually a technique reported where fundoplication is performed at the time of POEM, but extraluminally at the completion of the standard POEM procedure. This was reported in 2019. So here you can see basically the scope is down at the end of your submucosal tunnel. Myotomy has been performed. Here is the small layer of serosa that's being cauterized, and then the scope is fully introduced into the peritoneum. And then clips and an endoloop are essentially used to perform fundoplication. So this was described in a series of 21 patients. Outcomes were 100% technical success, a mean procedural time of about 2 hours. On the video here, this is at the end of the tunnel. They're doing cautery to break through the serosa and enter into the peritoneum. Here you can see the anterior wall of the stomach, and then the left lobe of the liver coming over across the stomach. They're grasping the stomach, and then at the same time, there's a pediatric endoscope which has been advanced through the standard esophageal lumen into the stomach and is in retroflexion. So you can see where they're grasping on the anterior stomach wall. The fundoplication portion only took 50 minutes. There were 0 adverse events. And then at 2-month follow-up, 95% of patients had a retained wrap structure, although this is really just kind of a safety and feasibility study, and there wasn't much reported in terms of outcomes. Here in the video, you can see they're fixating the endoloop to the anterior gastric wall with a couple clips. And then the endoloop is on the more proximal end is being fixed to the muscle at the end of the myotomy. This is during the loop fixation. After both ends are clipped, basically there's cinching of the endoloop and cutting. And then here's the end result. So we have basically this fundoplication or wrap structure. Okay, and then the last thing is after this was reported, basically the same technique was used for fundoplication alone, so without POEM or without the presence of achalasia. I'll jump to the video on this one. Okay, so again, the standard initiation basically is submucosal injection with mucosotomy and tunnel initiation. Then you have dissection of the submucosa and formation of a tunnel to the level of the gastric cardia. Once there, a myotomy is performed, but in this case it's just a short myotomy since the goal is not treatment of achalasia. After your full thickness myotomy, then the serosa is cauterized to break through into the peritoneum. Here's some final cautery happening for dissection. And there you can see the anterior wall of the stomach and the overlying peritoneum peeking through. Finally, they're fully in the peritoneal cavity, and similar to the prior procedure that was shown, the next step is the fundoplication. In this case, they're actually using a surgical suture with kind of a modified setup. So basically, you have the needle suture attached to a pledget. The needle is put into a hard hood to protect from inadvertent tissue injury, and then brought down through the tunnel. Okay, through the myotomy, into the peritoneum. So again, we have liver, left lobe, and then the overlying stomach. This is a view within the stomach, and you can see where they're compressing or impressing upon the stomach with the needle. This is an endoscopic suture holding device. This is a prototype. The suture is placed in the in the anterior wall of the stomach. And then retracted back to the level of the myotomy, which is at the level of the gastric cardia. Okay, this is being retracted back just to tighten things. And then the suture is placed through the muscle of the gastric cardia. This suture actually has barbs on it, so once it's tightened, there's nothing to do basically to fixate the other end. Okay, so you see tightening, and then they cut this, and again it's barbed so it won't fall back through. Okay, and then this is just the after picture, where we have partial fundoplication present. And then the follow-up endoscopy just showed healing of prior esophagitis and intact partial fundoplication. All right, thank you very much. That's it.
I have a quick question. I think we may not have time for a lot of questions. If there are no other questions, this is going back to, of course, what I'm going to ask you about, which is the gastric varices series that you asked, that you showed. So as I think of which ones are at risk in my own endoscopic practice, I always think of who I should send to you. And you noted that the average diameter was like 2.2 centimeters. I can't remember exactly. From that series or from your own practice, what would you, who should you see? Who are the higher risk patients? There were a couple of complications, but I think preventing a gastric variceal bleed is clearly a worthy outcome. At what size, or either small, medium, large, or maybe actual size, do you sense we should be sending all these patients to for primary prophylaxis?
Yeah, I mean, so I would say we have a protocol, but it's somewhat arbitrary. So I think initially we were doing anything over 2 centimeters, and that's talking about not the lumen of the varix itself, but the size of the complex. I think more recently, anything greater than 1 centimeter we've been treating. But I don't think that there's there's this natural history data from Dr. Sarin that I quoted from 1994 showing that, okay, IGV-1 type varices have a very high bleed rate. If it's GOV-2, it's lesser, and of course ectopic varices lesser. And then if it's GOV-1, then we just treat that with banding since they're considered an extension of the esophageal varices. But beyond that, I don't think that there's necessarily good data to guide a size. And the protocol we use was definitely sort of an arbitrary thing where we just picked a size. Of course, if there's stigmata of hemorrhage or prior bleeding, that makes it easy. But there's, I think, not a great determining factor. I will say that there's also studies looking in patients who have bled basically at just endoscopic direct glue injection versus glue coil. And one of the rationales for using EOS is that actually endoscopically the rate of detecting gastric varices in the study was about 10 to 15%, and on EOS they were seeing 67 to 70% of the time. So I think that if the gastric varices are seen, there's not necessarily endoscopically great or accurate sizing at the time. So at least examining the size with EOS will help to just people decide basically, is it worth treating?
Thanks. Andrew, thank you. Excellent sort of overview of various things. Firstly, thanks for giving me credit, but Abdul really is a motivated guy, so I'll assign it to him. In terms of the varices, the thing that I've always struggled with is how to know how the glue is going to behave. And we know that overall, as you mentioned, just endoscopic gluing seems to have pretty good outcomes. So we do the coiling in the glue, but I always wonder where that glue is going to end up. And just for full disclosure, we had an incident where the patient did have embolization, and on CT there was glue in the lungs. And she didn't have immediate mortality, but 4 weeks later she did pass, and she had metastatic cancer. So I just wonder, as a group, where we're going with the glue and coiling, given the additional cost and time. And we still continue to offer it, but your perspective on whether that is the future or whether the additional cost and lack of control maybe that we need to consider more IR-based approaches or a combined approach?
Mm-hmm. Yeah, I think one, certainly there's a difference between primary prophylaxis and secondary treatment, since we know that although gastric varices in total bleed less often than esophageal, when they do, it's potentially catastrophic. The type of glue, I think, is one thing to pay attention to. So, I think most of the studies actually report use of N2-butyl cyanoacrylate, which is, I think, makes sense if you're doing just direct endoscopic injection because it has a very fast polymerization time. Things to mitigate the risk of embolization, though, include, I think, one, using a different polymer. So there's the 2-octyl cyanoacrylate, which has a slower polymerization time, which if you use the same technique where you're just kind of jamming it in, trying to get it out before it hardens, then certainly that is potentially detrimental. So depending on the type of glue, you have to modify your technique and make sure that the nurse or the tech is actually putting glue in very, very slowly. Secondly, there are, of course, different techniques, and I think Chris Thompson at Brigham, they use basically a lot more fluoro to confirm obliteration, basically, of the variceal complex, to the point where they're putting in multiple more coils too. And then only once they show that there's no basically downstream flow of contrast, then they'll inject the glue. I think that the part of that is because we use the 2-octyl, and it's a slower, or it's a more viscous solution, we don't have to use the lipidiol. But certainly I think it's worth looking at more, does fluoro-guided obliteration with coils first decrease the risk of embolization further? But it's an open-ended question, and I think in part what prompted the coil therapy in the first place, or the combination therapy, was a similar event where with glue embolization there was a young patient that ended up dying. So I don't know if that exactly answers your question, but we're looking at more things to minimize the risk of pulmonary embolism.
Thanks so much, Andrew. I think we have to move on. You have to catch Andrew later at the break.